Good morning, everyone, and welcome to this edition of CareOregon's Meds Ed Primary Care Education Series. My name is Paul Carson, Training and Development Specialist with the Pharmacy team at CareOregon. Everybody who's enrolled in this session here today will be eligible for either CME credit or CEU credit hours. It just pretty much happens automatically for us. And that includes CEU from the local chapter of the National Association of Social Workers, and the regular AAFP CME credit is applicable for folks who need credit through the Oregon Board of Pharmacy. So bottom line, whatever you need, we're pretty much going to be able to take care of you as far as credit hours go. At the end of this session later on this afternoon, I'll mail all attendees a brief survey. All you need to do is just fill it out and make sure you got your email address in there correctly, and we'll be able to get your certificates for you by early next week. So that's a very simple process there. Real quickly, these are some of the overarching learning objectives that we're going to be covering in this session here today. You'll be able to identify how stigma creates barriers to evidence-based medical care for substance use disorders. We're going to review how the media influences stigma for everyone, including healthcare providers. We haven't been paying attention to the media at all in the last few months here, have we? Not whatsoever. So the media is a big influence, as we all know, and particularly when it comes to this topic here. You're also going to be able to define the 3 layers of stigma and be able to talk about how they impact care delivery for what we're doing. So it's a full plate of good content for you here today. I'm going to introduce our first presenter, our featured presenter here momentarily. I just wanted to set the stage for us as we start off today and just kind of remind everyone why we're here. I think it's a period of time that really behooves us dialing in on this topic. When we talk about stigma, we're talking about the discrimination of a group of people, a place, even a nation. It can lead to feelings of shame, hopelessness, and isolation. People who experience stigma may also have fewer opportunities for employment or social interaction, and they're probably a lot more likely to be bullied, harassed, or even physically assaulted. Stigma can prevent people from seeking help or getting diagnosed or even receiving treatment. It can also lead to substandard care, denial of care, or passing care off to less experienced staff, where we see it contributing to health disparities by influencing health outcomes in a negative way. Research shows that stigma is one of the primary barriers to accessing recovery services for people who use substances, which is a huge part of what we're trying to address here today. So I'd like to go ahead and introduce our featured presenter this morning, Lydia Bartholow, DNP, PMHNP, CARNAP, FIAAN, excuse me, is a doctorally prepared psychiatric nurse practitioner with a specialty in addiction medicine and trauma-informed care. She's the medical director of an emergency room that specializes in SUD-related crises in Portland, Oregon here, and is on faculty at University of California, San Francisco, as well as the Oregon Health and Science University. She speaks nationally on topics such as co-occurring disorders, harm reduction, and substance use disorder care system improvement, and is a fellow in the International Society of Addiction Nurses. She focuses all parts of her practice on radical public health, harm reduction, and anti-oppression work. Lydia lives in Oregon on Chinook, Cathlamet, Clackamas, and Kalapuya land. Please join us here in welcoming Lydia Bartholow. Take it away, my friend. Thank you.
Hi, good morning. Thank you so much for that lovely introduction, Paul. And extra thanks to Paul and Ian for bearing with me as I needed so much technical support this morning, and Paul for heading downtown to hang out with me at the CareOregon studio. That was awesome. Thank you so much. And I'm really glad to be here with all of you this morning talking about stigma, which is one of my favorite topics to talk about because I think it's so wildly impactful in the care that we provide and the care we deliver to our patients. I'm going to talk just a little bit today about who I am, and then we'll sort of dive into the topic. So Paul told you all a little bit about me, but I'll give just a little bit more background. First and foremost, I always identify as a nurse, and we'll actually come back around to why that is in a little bit. But as someone who's doctorally prepared, sometimes patients especially will try to call me doctor, and I always sort of reorient and say, actually, my training's really in nursing. And again, this is important in the setting of trauma-informed care, so we'll come back to that. Right now, I operate as the Substance Use Disorder Associate Medical Director over at Unity Center for Behavioral Health. Within the past year or so, Unity opened up a sort of a slice or a place within their emergency psychiatric services that tends to people that are utilizing substances or acutely intoxicated or have a substance use disorder. So the idea is it's sort of a slice in the emergency psychiatry services that tends to people that have co-occurring disorders or some kind of crisis in the setting of mental health and substance use, or substance use that's impacting their mental health. And I've been really honored to help start that over at Unity, and feeling really good about it. And if anyone has questions about it, happy to chat about it. I also teach over at UCSF, or I should say down at UCSF, the University of California, San Francisco. And then I teach in the School of Medicine here and the School of Nursing at OHSU, and primarily teach about addiction medicine. And in our topic today, it's important for you all to know that I'm also a person in long-term recovery. So when I'm chatting today, I'm talking sort of primarily as an academic, but also as a clinician that works in pretty large healthcare systems and an administrator. And then I'm also speaking as a person with lived experience of substance use and lived experience of accessing the services for recovery, and sort of understanding what that feels like, what it feels like to talk with healthcare providers about utilizing substances. I'm also a big lover of bully breed dogs, so you're going to see some bully breeds throughout the slideshow today, and we can chat a little bit more about why that's important. Historically, I've included a lot of bully breed dog pictures because I've always had pitties and various bully breeds. We actually don't have a pit bull right now. In this really bizarre turn of events, for the first time in 10 years, we have a Chihuahua mix. It's a Chihuahua Lab Husky, and he is 7 months old, and he is the opposite of a bully breed dog in personality and look. And I adore him, and it's also a really big change. I'm also, right now, I'm really, really into Chappell Roan and Zach Bryan. And if we were in person, I would try to see who was really into Chappell Roan and who was really into Zach Bryan. And then I would be especially interested for the overlap, because that's kind of an interesting Venn diagram. I can't see the chat, but if you want to just like give a shout out to Chappell Roan or Zach Bryan, or if you're someone that, like me, that kind of oddly likes both, I would love to hear about it. And then sort of most importantly for our topic today is that I have been, for the last several years, doing a lot of consulting around trauma-informed care, specifically for substance use disorders. So probably about 5 years ago, I started helping organizations, clinics, large medical systems understand how to bring trauma-informed care into service provision for people that were accessing services for substance use disorders. And I always was working sort of intimately with administrators, and then often doing a lot of education with staff. And what I found over a pretty long period of time, I found that I could go in and I could do training, and people would get really, really excited about the content. They would feel like this is something they wanted to do. They wanted to provide more trauma-informed care for people with addiction. They wanted to provide more patient-centered services for people that were utilizing substances. Or administrators were really, really eager to build systems that supported people in a trauma-informed way. And yet, over and over again, when I went back, what I found was that people were having a really hard time implementing things or changing service provision. And part of that is just the nature of the work. When you do consulting work, and let's say you do like a 1 or 2 off training, or maybe a 3-part series on trauma-informed care for substance use disorders, that doesn't necessarily mean that things are going to change dramatically. People often get excited, and then we tend to, and it's just human nature, we tend to fall back into what we know and what we do. And so part of that's to be expected. And I actually sort of changed my model to say I won't do just one-off educational gigs because I don't think it really helps change the culture. But there was also sort of a bigger layer underneath that. And so when I did some sort of deep dives into what was preventing people from really changing the culture about how they provided care to people with substance use disorders, to be more aware of trauma, to be more understanding of trauma, and then to resist re-traumatization, what I found over and over again is there's sort of one core theme that things would distill down to. And by and large, it was stigma. By and large, people had a really hard time changing the way that they provided care because this sort of invisible barrier was always in the way. And that barrier was stigma. And it was such a huge barrier because it's so invisible. You know, we're not trained to recognize where stigma is and how our thinking has been influenced by sort of pop culture or what we see in media. We're not trained to like investigate that. And so then we go in and we're trying to provide evidence-based medical care, and we're completely blinded. And I say we because I really do include myself in this. We're completely blind to the way in which these cultural stories that we've been told about substance use disorders and who the people with substance use disorders are and what causes them. We're sort of blinded to the way those cultural stories are influencing our medical care, which is a huge bummer because it turns out so many of those cultural stories don't actually align with evidence-based medical practices. So that's where we arrive today. The sort of impetus for this is to allow people to understand sort of the role that stigma plays in how we make clinical decisions around substance use disorders, and to start to unpack that ever so slightly. And so I don't have any disclosures. I'll say that really quick. There's a really cute bully breed dog, not one of my bully breed dogs, but there's a cute bully breed dog for you to get us started off in the right way in the morning. And as we go through the material today, what I'm going to do is I'm going to pull in sort of pop culture references, and then I'm going to pull in some literature from the medical evidence. And the idea here is we sort of interweave those things and we see the ways in which stigma starts to be sort of a major player, both in these cultural narratives that you're going to see created in media, just as an example. And then we're going to sort of interweave that with what the medical evidence says. And my hope is that by the end of this, you'll really have an understanding of how much you're sort of, the stories that you hold on to internally have been influenced by things that aren't based in the medical evidence. So we'll start with that sort of intermediate interactive media and evidence review. Then we'll do a little bit of a deeper dive into the literature regarding the role of stigma and substance use disorders. Then we'll do a little bit more interactive media review. Then we're going to understand the layers of stigma. And I'll probably spend a pretty big chunk of today talking about the layers of stigma. And this is really because the feedback I've gotten on this talk before, like I'll run into someone at like New Seasons, let's say. I'll run into someone at New Seasons and they'll be like, you know, when you pointed out the layers of stigma, they are embedded in my mind now, and I see everything through that lens. And I unpack things through that lens. And so because I've gotten feedback that this piece is really important, we'll kind of hang out here for a while today, and we'll sort of talk a lot there. Then we'll do maybe a little bit more interactive media and evidence review. We're going to talk about race and marginalization and how that creates sort of overlapping stigmas. And then finally, we're going to have an actionable takeaway around language. We actually have a lot of time together today. I'm used to giving this talk and not very much time. We have a chunk of time together today. So I have an extra takeaway around how to do patient education around substance use in a destigmatized, trauma-informed way. And if we have time, which I think we will, I also want to include that in your sort of actionable takeaways. I always hate to learn really, really cool things and then feel like I left not knowing exactly how to implement it. So my hope is that we'll have some sort of interactive review where you have a chance to unpack what you know and think about substance use disorders, interspersed with the medical evidence. And then at the end, we'll take some time to think about how we can make that knowledge really actionable in the clinical setting. Again, it's always tricky to learn this really conceptual stuff, but not necessarily have tools on how to implement that in your day-to-day. So we want it to be conceptual and sort of change the way you're thinking, but also give you some tools. And this is where I'm going to need a little bit of support from Paul and Ian, because we talked about this, but I actually don't remember now, because I'm going to need to see what you guys put in the chat. What I want to do next is I want you guys to name as many people that you can think of from the media that are portrayed positively and either have or had a substance use disorder, and that substance use disorder is in remission. And when I say positively, don't start going too soon yet, but when I say positively, this means someone who's not selfish, not portrayed as selfish, and is either able to recover or has recovered. And their sort of story, or the way their character is portrayed, is not intertwined with criminality. And when I say media, right now specifically, I'm looking for fictional characters. So I want you to think of sitcoms and movies. We don't have to talk about media in terms of politics. Not right now. It's kind of too soon for me to talk about politics, too early in the morning. So when I say media, I'm talking about fictional characters. And again, they're portrayed positively. So they're portrayed as someone who's not selfish. They're able to recover or have recovered. So their substance use disorder is in remission. And their sort of like arc, the narrative arc of who they are, is not intertwined with criminality. Okay, go ahead. I'm seeing a couple things in here. Karen Kern says, this is a tough one. I thought of Russell Brand, but he's not a character. Yep, totally. He's not a character. Oh, and I see someone saying, I don't know who Zach Bryan is, so I'm far off from the Venn diagram. So I'm going to go back a little bit because I highly suggest Zach Bryan, but very, very, very different than Chapel Roan. But definitely check him out. Ooh, okay. Someone says Loudermilk. And while more of these are coming in, let's just chat on Loudermilk for a second, because people often mention Loudermilk at this point in the exercise. And I think Loudermilk is really useful for us to talk about. It's tricky. Loudermilk, able to recover, absolutely. Narrative arc of who he is, not intertwined with criminality. True. I also think of him as being portrayed as wildly selfish and not all that self-aware. Rachel, this was a comment from you, so I'm curious. Do you think of him as selfish or not? Okay, Rachel says Loudermilk portrayed as selfish. Okay, thank you, Rachel. Who else can you guys think of? And if you can't think of anyone else, I would be wildly surprised. And also, I wouldn't be surprised at all. And you guys can probably guess why I wouldn't be all that surprised. Ted Danson in Cheers. Yeah, this is like the classic one. Ted Danson in Cheers. He's not portrayed as selfish. He's portrayed as being able to recover. And his character's not intertwined with criminality. Absolutely. Okay, so we got Ted Danson in Cheers and like maybe a little bit Loudermilk. Okay. So we got two, but Loudermilk's questionable, and Ted Danson and Loudermilk have a couple things in common. And for the sake of today, I'm just going to highlight Ted Danson and Loudermilk, both white guys, right? Both straight white guys. Okay. Ooh, okay. Rachel says, I think about the show Euphoria, but there's a lot of selfish storyline in there. I do think, though, that Euphoria does a great job of portraying substance use disorders where there's not a lot of selfishness. There is some sort of troubled things in the storyline, definitely some hopelessness, which shows up in substance use disorders, but not a lot of criminality. And then Kelly said the sitcom Mom. And you know what? I'm so embarrassed. Kelly, will you text me later and remind me to watch this? Because people bring this up all the time. People say, hey, Mom does a great portrayal where there's not selfishness, someone's able to recover, has recovered, and they're not a criminal. And I've never seen it. So I need to go watch it. Ooh, someone said Leo McGarry from The West Wing. Thank you for that. Thank you for mentioning Leo McGarry from The West Wing. And a special thank you because Leo McGarry from The West Wing really, really stands out in my mind. He stands out because Leo McGarry was the first time that I ever remember watching TV and noting that my story was being told. There was people going to meetings, they were portrayed positively. Leo McGarry wasn't portrayed as selfish, he wasn't portrayed as a criminal. He had a lot of agency in his own life. I was like, hey, this sort of feels like my story. But then also, Leo McGarry was this older white guy. So then in this other way, it wasn't my story at all. And it wasn't the story of so many people that I loved and cared about. So now we've got Loudermilk, we've got Ted Danson, we've got Leo McGarry, the mom from Mom. I see 2.5 Men, Charlie Sheen's character. I actually haven't seen it. You're anonymous, so I can't tell you to message me later and watch this because I'll probably forget, but I'll try to remember. 2.5 Men. And someone said Roseanne from the television show, and I'm trying to remember. I don't think of Roseanne in the show as having a substance use disorder. Will someone remind me if I get it wrong? Did she have a substance use disorder in the television show, her fictional character? Ooh, okay. Tyler says the father from This Is Us. Absolutely. I always, and there's actually 2 fathers from This Is Us portrayed as having a substance use disorder. I think the father from This Is Us that you're referring to, who I always call the hot dad, the hot dad has a substance use disorder. The white father, who's like really one of the primary characters, has a substance use disorder. Absolutely portrayed as not being selfish. Absolutely portrayed as being able to recover, and no criminality intertwined in his character. And Tyler, I love so much that you brought it up because I think that This Is Us actually does an incredible, incredible job of portraying substance use disorders, and it's actually really meaningful. So let's sort of like hang out. Let's sort of hang out there for a second. So here's the themes that I've heard you guys say. That this was really hard. And even if that's the one thing that we took away from this is really hard, that's useful. Because when I think about my work with people every day who have substance use disorders, I'm working with all kinds of folks that aren't quote unquote criminals. I'm working with all kinds of people that have the ability to recover. Indeed, we know that recovery is the norm. It's not the outlier, it's the norm, and we'll come back to that. And they're absolutely not selfish. But the cultural narrative that we've been told, and that we see sort of repeated back to us from fictional characters, is that people with substance use disorders are criminals, that they're selfish, and that recovery isn't something that happens. And I want to highlight here a couple of the initial characters you thought of, which are really, really great examples. They're all white men. And then we got a couple towards the end that weren't, but they sort of trickled in towards the end. And also they're newer TV shows, which I think really says something about the way in which representation is shifting. So one of them is Euphoria. There's a couple characters that are not white men, absolutely great representations of substance use disorders. There's an African-American dad in This Is Us, doesn't have as major role as the white dad in This Is Us that I always call the hot dad, lesser role, and absolutely fabulous portrayal of substance use disorders. Okay, so we got that it's hard, that a lot of the narratives we've seen are older white men, and that more recently we're seeing better portrayals. And truly, if you haven't seen Euphoria, and you're interested in sort of portrayals of substance use disorders, if you haven't seen Euphoria and you haven't seen This Is Us, I would say watch them. Euphoria is not for the faint of heart. It's a tricky one. This Is Us is like a little bit more soapy, kind of a fun show. I also see someone said Jesse Pinkman from Breaking Bad. And, you know, I need to go back and I need to watch that. Chance, if you message me later, remind me to watch Breaking Bad again. I don't think of Jesse Pinkman as being showed as able to recover But also, I don't know that I watched it to the end, so I need to rewatch it. He's kind of a criminal. Paul's whispering in my ear. He's kind of a criminal, which I think is true. Certainly Walter White was sort of like forced into criminality, but I think of Jesse as being like there to invite Walter White in. So like very intertwined with criminality. But again, it's been a minute since I've watched it, so I'll try to remember to watch it. Michael says Salt High and Battlestar Galactica. That's another one that I need to watch again. Paul is mouthing to me, it's so good. And is that a Joss Whedon? Am I thinking correctly that Joss Whedon?
More.
Oh, okay. No Joss Whedon up in there. Okay, I'll still go back and watch it though. Okay, great. Anyone else you guys want to mention? Okay, someone said, I would agree. I don't think I saw Jesse Pinkman recover at all during that series. And then someone said Dr. Abby Lockhart from ER, which is like totally new to me. I guess I need to watch ER. I feel like I've never even heard of that show or movie. So now I got more to watch. This is great. You guys are helping me with my things for me to do this winter when it's dark and cold. All right. So I want you to just think for a second now, what are your key takeaways from that? And there's some things that we didn't touch on here, but I want you to just think, what are your key takeaways from doing that ever so brief exercise? And you can just sort of think it to yourself. You can jot it down if you want. Someone said, if we're going Joss Whedon, then Willow from Buffy. I think there is an argument to be made that Willow got pulled into some magic in a way that's very similar to the development of a substance use disorder. So yeah, I think we could talk about it in that sense. Absolutely. Okay, so then let's pivot. Oh, these are my, I don't live with either of these dogs anymore, but let's pivot and let's talk about the medical evidence. The medical evidence says, and this is sort of what I call a non-exhaustive lit review, where I've pulled out what I think are some of the more compelling pieces of literature for the last 10 years or so. And pretty soon I'm going to have to update this because really some of the seminal work comes around 2014. So this is getting pretty old at this point. But I pull this out because, again, it's pretty seminal. And what it says, and it really opened up the doors to a lot of research and sort of public health campaigns thinking about stigma. What it says is, and I'll just read you their conclusion. This is a pretty big meta-analysis. And so just think for a second, what's a meta-analysis? And the reason I mention it's a meta-analysis is because meta-analyses, we think of them as carrying more weight in the medical literature. When you're looking through medical literature, there's a couple things that carry more weight and might mean a little bit more. So again, I pulled this out because it was seminal, it's a medical analysis, and it sort of shifted the way that we were thinking about where to put prevention money and sort of non-treatment money. And I think of like where we put money is where we place value. So we started to place more value in understanding the role of stigma as it pertained to substance use disorders and their treatment. So here's the conclusion that this pretty big meta-analysis came to. Stigmatization was the strongest predictor of substance dependence. Anti-stigmatization prevention and outreach programs are needed to overcome the reluctance of this clientele to use healthcare services. And remember, this is 2014, so they're using DSM-4 language of substance dependence. We wouldn't talk about it this way today. We would talk about substance use disorders. But at the time, the way that this was talked about was substance dependence. And what they're saying is that they pulled through a bunch of different studies. They pulled through and they gathered data from across disciplines and a bunch of different types of studies. And they found that stigmatization was the strongest predictor of persistent substance dependence. And that helping healthcare professionals with anti-stigmatization and prevention was needed to overcome the reluctance of this clientele to use healthcare services. And so I think it's such interesting wording here. And remember, we're going back 10 years. Needed to overcome the reluctance of this clientele to use healthcare services. I don't know about you all, but in my mind, this actually sounds a little bit stigmatizing to me. Like it puts the onus on the consumer here. It puts the onus on the patient or the client. There's a reluctance of the clientele. And the way that we would sort of talk about this now is that our systems have to learn to destigmatize so that people want to engage in healthcare services. Because what we know is that stigma and experiences of being self-stigmatized or interpersonal stigma makes it so people don't want to engage in care. So what this is saying is that the way that people, if we sort of distill this down, the way that people are treated when they try to access recovery services and other medical services makes it so that they don't want to engage in care, which is pretty big. I mean, it's a pretty big sort of, it's a pretty telling statement here. The way that folks are treated when they try to engage in recovery services, or the way that they experience their treatment, I should say, is probably more accurate, is what can either propel someone to engage in more care or repel someone away from care. So this huge meta-analysis found that the way that people experience their care is part of what either brings them into care or pushes them away from care. So we've spent all of this time thinking about what is evidence-based treatment for substance use disorders, but this meta-analysis in 2014 sort of pivoted us to think about how do we engage patients? How do we think about making our services less stigmatized so that people want to and feel propelled to engage in our medical care, people that are utilizing substances? And I want us to sort of move forward in the literature a little bit. So again, that was 2014. And I want us to just move forward to 2019, because between 2014 and 2019, unfortunately, in terms of the opioid overdose crisis, things got a lot worse. So things didn't improve. We started to think more about patient engagement. We started to think more about stigma. But unfortunately, things didn't get better when we thought about the opioid overdose crisis. And indeed, things were actually getting worse in the opioid overdose crisis from 2014 to 2019. And we were seeing a lot more harm and overdoses related to methamphetamines or methamphetamine-related harms in terms of public health outcomes. So Alexander Tsai was the PI on this study, and I mentioned Alexander Tsai because he's just one of my favorite sort of thinkers and researchers. And what the conclusion here that they found that I think is so useful for us to highlight is, and so well worded, is public stigma and enacted stigma, don't worry, we'll come back to these, can become structural stigma when they become encoded in cultural norms. So we're moving forward from 2014 to 2019 and talking about public stigma and enacted stigma that become structural stigma when they become encoded in cultural norms. And my hope is right around now, you're thinking about cultural norms, you're thinking about those stories that we see sort of told back to us in fictional characters. Those cultural norms are the stories that were told back to us and the stories that then we are going to carry. And they're also going to influence our laws and our institutional policies. So stigma becomes these cultural stories or these cultural norms, and then that becomes laws and institutional policies. Collectively, these forms of stigma run at cross purposes to and reduce public support for public health-oriented policies to address the opioid overdose crisis. So we're saying, hey, it's not just the way that people are treated when they come into care, but also these narratives that inform the way people are treated when they come into care. Are these cultural stories we have also become laws and institutional policies, and that becomes structural. And so let's just hang out for a second and talk a little bit about how we're using the term structural here. If you ever see me give a talk, you're almost always going to hear me talk about structures. When I'm talking about structures, I'm not talking about buildings as much as I really, really like architecture. When I talk about structures, and just think for a second, and if I had sort of easy way to make this more interactive, I would, but just think for a second. When we're thinking about structures here, what are we thinking about? What are we meaning? not buildings. So what do we mean by structural? Structural here is sort of a nod to things that are large and often invisible and influence so much of our daily lives that are embedded in laws and institutions and cultural norms. So oftentimes when we're talking about structural forces, we're talking about things like structural racism, or we're talking about structures that perpetuate poverty, or we're talking about structural gender-based violence. So we're looking at the things that often prohibit people from finding health and wellness that are often invisible and sort of baked in to larger systems. The easiest way for people to think about structural is often thinking about structural racism. So think about things that influence structural racism, like educational systems, the prison industrial complex, things that influence ultimately health and wellness and inform our lives, but are often these large and almost sort of invisible things, structures that influence so much. And so what this is saying is public stigma and enacted stigma, and we'll come back to all these terms, don't worry, we'll sort of like sparse this out and define things, become structural. And those structures then influence institutional policies, laws, and the stories that clinicians tell about people who use substances, and of course, what causes substance use disorder, and what those people are like and who they are. And this is it's so broad and so sort of all-encompassing, these cultural norms that become structural, that even when people are in deep grief, we carry these stigmatized narratives about substance use and substance use disorders. And so I mentioned this one because we just spent some time thinking about structures, which can feel sort of nebulous and dehumanized. And I wanted to sort of bring it home how incredibly personal and human this is. So the title of this article is Nothing to Mourn, He Was a Drug Addict, Stigma Towards People Bereaved by Drug-Related Deaths. And here was their sort of, they call it the result or their conclusion statement. Nearly half of respondents, and they are talking about people that have lost family members or loved ones to drug-related deaths. Nearly half of the respondents reported experiencing derogatory remarks from close and extended family and friends, work colleagues, neighbors, media, social media, and professionals. The main themes were dehumanizing labeling, unspoken and implicit stigma, blaming the deceased that the death was the only and the best outcome, which, by the way, is a cultural narrative that we carry, that recovery is not possible. So blaming the deceased that the death was the only and the best outcomes. The remarks were negative and powerful despite being directed at people in crisis and originating from individuals close to the bereaved participants. So again, to sort of unpack this, I put this in here because we just talked about structural. And so I wanted to sort of bring home how deep this is, some of the cultural narratives. And I think especially here, what we can highlight is this dehumanizing labeling that persists even in these moments of deep, deep grief and sorrow. And then also the blaming of the deceased that the death was the only and the best outcome. So remember again, when I said, what do you see in, or when I asked you to talk about fictional characters, and one of the things that I asked you to highlight was people that were showed as being able to recover, or someone whose substance use disorder was in remission, or they were or had recovered, I should say. And one of the things that you'll see come up over and over again in our cultural narratives is that essentially that addiction is a fatal illness and the recovery doesn't happen. And this one always blows my mind, because what the research says is actually that recovery is the norm, and that people stop using substances in harmful ways more often than not. And I'm happy to share that evidence with you. I always forget to go back in and put it in here, but it's this cultural narrative that we carry, that people that are using substances are selfish, that they're intertwined with criminality, especially if they're not white men, that their sort of arc is intertwined with criminality, and that recovery is not possible. Although, again, the medical evidence says that it's the norm. And you see those cultural narratives being repeated even in these incredibly intimate, tender moments when people are in crisis related to losing a loved one to a drug-related death. And let's move on to the next piece here, which comes from Nora Volkov. And this is an opinion piece. And so you might be surprised that I'm including an opinion piece as I do a literature review of the medical evidence, but it's Nora Volkov. We don't have time to sort of dive into too much around Nora Volkov, but she is the director of NIDA. So she's the director of the National Institute of Drug Abuse. And she's kind of a big deal. And if anyone's ever been to the Blue House in Mexico City, Nora Volkov actually grew up right next door in Leon Trotsky's house in Mexico City. So she grew up in Mexico City, moved to the US, and sort of rose pretty quickly as this like incredible researcher and thinker when it comes to substance use disorders. And so I always sort of go back to what Nora Volkov says, because her life's work is thinking about the neuroscience of substance use disorders and addiction, and then thinking about what we can do at a really broad level. So she's the director of NIDA. So she's thinking about things not sort of at a like, how do we treat one person level, but she's thinking very much at a population-based level. And then she's really also interested in the neuroscience. So when Nora Volkov talks, I often listen. So I pull this opinion piece because it's Nora Volkov, and she's just an incredible thinker, and she's thinking about this from a couple of different directions. And what Nora Volkov says, stigma not only impedes care delivery. So remember, the very first thing that we saw from 2014 was thinking about how people are propelled away from treatment services, primarily in terms of how they're treated by providers. So stigma not only impedes care delivery, and then also we know people get different care based on those cultural narratives that we have. It also likely causes us to underestimate the burden of substance use disorders in the population. And this one makes me think of the one we just looked at, which is people and how even in these moments of like deep grief and tenderness, people continue to dehumanize the folks that were lost and tell these not evidence-based, not very accurate narratives about people that have substance use disorders. And if you experience that someone with a substance use disorder is dehumanized even in those moments, think about what that means on a broader term for how often we talk about and pay attention to drug-related harms and substance use disorders overall. So if there's that much sort of stigma and shame, that means that we're going to think about it less, we're going to do less research around it, and we're going to talk about our personal experiences of substance use disorders and things associated with them even less. So it causes us to underestimate the burden of substance use disorders in the population, but it plays an even larger role in this crisis, she says. And this is where I want us to hang out for a second. One that has even been less discussed. When internalized, stigma and the painful isolation it produces encourage further drug taking, directly exacerbating the disease. So I'll just read that again because I think it's so powerful. When internalized, stigma and the painful isolation it produces encourage further drug taking, directly exacerbating the disease. And what she's actually highlighting here is something that she talks about the neurobiology of very, very well. The neurobiology of shame, which increases our stress hormones, and elevations in those stress hormones actually make us more likely to use substances. So those stress hormones, as they go up, especially cortisol, as stress hormones go up, our ability to manage cravings and our ability to sort of engage in our prefrontal cortex and then not use substances actually gets smaller. So the more internalized stigma, the more internalized shame we have, we're actually more likely to utilize substances. So now we've sort of taken a pathway of looking at cultural narratives as shown in fictional media portrayal. And then we looked specifically at like this huge meta-analysis about how care is provided. We thought about that specifically in terms of things becoming structural. So we have these deep cultural narratives that then become structural, and they influence laws and policies. They influence the way care is provided. They influence how things show up even in these awful moments of grief where there's a lot of tenderness and you would expect maybe a little bit more humanity. And then they ultimately impact how often people experience shame, and then that impacts how often people use substances. And so I want to bring it back around because we're, if you're here, you're likely providing healthcare. I want to bring it back around just for a second to what we know about interpersonal stigma and how people who use substances show up in the medical setting and change their behavior. And so this one is called Strategies Used by People Who Inject Drugs to Avoid Stigma in Healthcare. So essentially the idea is that people who are using substances, and in this case, we're talking about people who inject drugs, how people who inject drugs avoid stigma in healthcare. And I'm just going to read this for us because I think there's so much good stuff in here. Experiences of dehumanization in healthcare settings were common, with many participants perceiving that they had been treated unfairly or discriminated against due to their injection drug use. And I think there's a couple useful things just right there. Many participants perceiving that they had been treated unfairly or discriminated against. And so I want to highlight the word perceiving, because I want you to think for a second, if you're in healthcare, you likely are aware and you've heard narratives from your patients about ways in which they've been treated. And so we know that this is not just about perception. People often are treated unfairly and discriminated against. And when people experience a lot of shame and self-stigma, they are going to read things that aren't necessarily stigmatized as being about stigma. So even if we do everything perfectly, if we often don't sort of overcorrect, people may experience stigma and may experience shaming regardless. And we'll come back to this. I want to just highlight here, many patients perceiving that they had been treated unfairly, we know they are treated unfairly, and even if we do things perfectly, people may perceive that they're treated unfairly because they're carrying years and years of this, as well as the sort of internalized shame and stigma. As participants anticipated this type of stigma from healthcare providers, they developed strategies to avoid it, including delaying presentation for healthcare, so not showing up when they know they should for healthcare services, not disclosing drug use, downplaying pain, and seeking care elsewhere. And this one I often talk about in the hospital setting, because what we know from the medical evidence is that people often experience more stigma in large institutional healthcare settings like hospitals than they do in what this article calls CBOs, community-based organizations. And participants of this study felt that they experienced greater acceptance, more mutual respect, and stronger connections with staff. And I highlight this because I'm someone that worked in community-based setting for the bulk of my career, and very recently transitioned to a hospital. And so much of I see my work in a hospital is just decreasing the experience of stigma in the hospital setting, because we know that it's so big for people that are utilizing substances. And then people will delay care in the hospital setting, delay care for really for good medical indications, and then will change the way that they present care, which means that their healthcare needs are not always going to be met. All right. So we just did a quick overview of a lot of different studies and opinion pieces. And again, I call it a sort of brief targeted lit review because I pulled out things that I think are particularly useful to look at. And now I want to give you guys just a quick pop quiz. And I want us to think about sort of some of the narratives that show up and that we sort of carry. And how often we think these things are accurate and true, even when they're not always based on the medical evidence. So I want you guys to just tell me true or false. And Paul has moved over so that I can see Paul's screen. So if you guys want to put things in the chat, that is absolutely okay. Also, you can also just sort of think through it or write notes to yourself. So which of the following statements is backed by the evidence? Client accountability is useful in addiction treatment. True or false? Just think about it for a second. Have you seen medical evidence that shows us that accountability is useful in addiction treatment? Or did you learn that client accountability is useful in addiction treatment from cultural narratives? Karen Kern says, define accountability. I love it. Great question, Karen. All right, number 2, urine drug screens encourage honesty and engagement. They are the blood pressure of addiction treatment. True or false? The medical evidence shows us that urine drug screens are useful when we're treating people with substance use disorders. Have you seen medical evidence that verifies that urine drug screens are useful in outcomes or in client engagement or any part of addiction treatment? Or is this something that is sort of part of a larger cultural narrative? Rachel Susher says false, but I've always been taught it from cultural narratives. Don't work harder than the client is working. And I think Rachel's speaking to number 1, client accountability is useful in addiction treatment. And then let's pivot to 3, addicts lie. It's part of the disease. And I want you to just think about, and this one's particularly, I think, salient in terms of thinking about how addiction has been told, the narrative addiction has been told back to us. So true or false, addicts lie, it's part of the disease. Great. And someone whose name is Michelle says, I do not find urine drug screens to be helpful in addiction treatment. I would be surprised if there was any evidence to support their efficacy. And Anonymous said, accountability, no. Client self-determination, yes. I love it. You guys are so smart and so good. I love it. Okay, so then let's dive through these and I'll tell you guys what the medical evidence says. There is almost no evidence that says client accountability is useful in addiction treatment. Karen Kern asked an incredibly poignant question. What does accountability mean? Because we know that, of course, agency and client self-direction and clients writing their own care plans and then having plans for when those care plans fall apart, that's incredibly useful. But we have this old cultural narrative that clients need to be accountable. And we really don't have any reason to see this reflected back to us in the medical evidence. Indeed, things like motivational interviewing, which are the most evidence-based sort of psychotherapies and interviewing strategies for tending to people that have substance use disorders, they actually really move away from the idea of accountability. In motivational interviewing, which again is the most evidence-based thing we have in terms of how we talk to clients about their substance use disorders, really tells us that accountability is almost not useful. When you find resistance, you sort of navigate that resistance, but you don't necessarily push and try to hold people, quote unquote, accountable. So long story short, we don't have any evidence, but you see it pretty frequently in sort of common cultural narratives of how to tend to people that have substance use disorders. Ooh, I'm losing my ear pods. All right. Number 2, urine drug screens. Urine drug screens encourage honesty and engagement. They are the blood pressure of addiction treatment. We have no evidence. It's something we've always done. It's something we've always done, but there's no evidence that urine drug screens actually change outcomes or engagement in substance use disorder services. Sometimes I find urine drug screens to be incredibly useful. For example, urine drug screen in the emergency room setting is so very useful for me. So many clients I find don't know that they are using fentanyl. They'll tell me, I'm just using methamphetamines. And then I get to say, hey, actually, you're using a little bit of fentanyl. And we get to have an incredible harm reduction conversation about keeping themselves safe in the era of fentanyl. But routine urine drug screens, there's no medical evidence that they actually change outcomes or that they change engagement. If we need to do them, there's absolutely trauma-informed ways of doing this. In fact, there's a couple of really good published articles, medical evidence on how to do urine drug screens from a more trauma-informed perspective. So it's not that we would never utilize them, but we don't actually have a lot of evidence for them. And then this third one, again, I love talking about this so much because I love thinking about things that we all do to decrease experiences of shame and stigma. And you can just sort of like energetically raise your hand if it might be useful. Have you ever misled a healthcare provider in terms of your healthcare behaviors? Paul is sitting next to me, so I can see him sort of chuckling a little bit. Paul, will you just share with me really quick if you feel comfortable? Gosh, I've really put you on stage, haven't I? Have you ever misled a healthcare provider about your health-related behaviors?
I would say yes. I would say I probably have.
Paul says yes, he probably has. And I gotta say that I certainly have. I have a doctorate essentially in translational health research, and I still will like sort of not be the most honest with my healthcare provider. So you go in and they're like, how many, minutes of exercise did you get this week? And I'm always like, oh yeah.
I'm exercising 5 days a week.
I did 45 minutes, 5 days this week of aerobic exercise. And, actually lately I have been exercising a lot. So like I'm getting closer, but I can't tell you how many times I told a healthcare provider that I was exercising more than I actually was. Or I told a healthcare provider that I had stopped drinking Diet Coke when like actually I was waking up and having a huge Diet Coke first thing in the morning to get my day started. So we all, and maybe not all, most of us are going to modify the truth in an effort to decrease shame and internalized stigma. It's something that we all do. And especially, someone said in the chat, I floss every single day. Yeah, Nichelle, me too. I totally floss every day, morning and night. Absolutely. I do it for 30 seconds in the morning and 30 seconds at night. And if you ask any dentist, you would tell them that's exactly what I report. So this idea that addicts lie, it's such a part of our cultural narrative. It's such a part of addiction. And yet when you look in the DSM, lying is not one of the diagnostic criteria, but people will change narratives to avoid shame and stigma. And it's part of why motivational interviewing, for example, is so dang effective, because outside of shame and stigma, people often embrace the things that they're not that happy about and that they want to change. But in the setting of shame and stigma, or even perceived, oh, there might be some shame and stigma on the other side of this, people will change their narratives. All right, so thanks for doing that pop quiz with me. It's one of my favorites. I'm going to have you guys do another sort of exercise here. I want you next to do the same exercise we did at the very beginning. So I want you to think of people from the media. And when I say media here, I'm thinking about fictional narratives, so sitcoms, movies, etc. And I want you to try to find people that aren't portrayed as being selfish. They're portrayed as being able to recover, have recovered, or have a substance use disorder in remission. And their narrative, sort of the arc of who they are and their character, is not intertwined with criminality. How many people can you get? Also, Nichelle, I just love that you said flossing. I've never mentioned that and as an example before, because I just have so many health-related behaviors that I'm afraid of shame and stigma around. I just realized I also do this with flossing. I'm like, oh yeah, I floss. And when I do, I use the actual floss. I don't use those little pick things. That's a lie. I only use the little pick things to floss. All right, so I'll give you guys a couple of minutes to think about this. Who do you got that's characters of color? BIPOC only, not selfish, able to recover, or in remission, not a criminal. And Elizabeth O'Rourke is replying, I think, to those pop quizzes and says, I don't know of medical evidence for any of these. 15 years ago when getting a CADC, these were the values that many counselors in recovery shared with me. So it takes time to unlearn older schools of thought. And Elizabeth, I think that is so well said. And it's so meaningful because what we're talking about here is these cultural narratives, these stories that have been passed down, whether it's movies or our mentors. And the idea here is these stories have been shared with us in whatever way, and we're going to start to interrogate them. Is that about stigma, or is that about the medical evidence? Is that about stigma, or is that actually beneficial to my client? So thank you for saying that. And especially thanks for being vulnerable. It's really hard to unlearn this stuff, including for myself. And one of the hardest places to unlearn is those places where we've got what I would call intersecting stigmas. And so when we're talking about BIPOC characters or other marginalized folks, fictional characters of color, we're talking about intersectional stigma. Who'd you guys get? Anybody get any characters? I love that there's silence. I mean, I don't love it, but I think the silence is actually incredibly telling. Someone said, I can't think of any, which makes me so sad. And there are a couple. This Is Us has great representation of substance use disorder and addiction with an older African-American man, and does just an incredible job of it. Euphoria, again, has characters of color struggling with substance use disorders who are portrayed fabulously. And both Euphoria and This Is Us are just in the last 5 years or so. It's really, really hard to find characters of color with substance use disorders that are portrayed positively if you go back before 2017-ish. And so I want to highlight this because we're all carrying around internalized racism, and we're all carrying around these narratives about who people with substance use disorders are. And so this is the place where I want us to be especially mindful. We're going to really unpack, like, what's going on here? What's the cultural narrative that I'm carrying right here? Because people are likely to experience multiple different intersecting stigmas when they come into the healthcare setting. Folks of color, trans folks, folks who identify as queer, lesbian, gay, people who are poor. Anytime there's marginalization and then there's also a substance use disorder, you're going to get overlaps. And so we're going to be especially mindful of unpacking what our sort of invisible narratives are, because we have had so few opportunity to see representation of people with substance use disorders that's accurate and evidence-based. And we've had extra few opportunities to see representation of marginalized folks that also have substance use disorders. We don't have great representation as is, but this is a place where it's really, really like sort of extra big. And I really think about this one a lot because, again, Leo McGarry was how I started to think about media and representation around substance use disorders. I'm interested in representation around all things. As a parent of a trans kiddo, I'm very interested in how trans folks are represented because I see what she's learning about herself from a young age. But Leo McGarry is how Leo McGarry from The West Wing, which great TV show, by the way, highly recommend if you haven't seen it. But he's really how I started to think about this, because in this one way, he was very much reflecting back positive representation of folks in recovery. And it was so meaningful for me. And also in this other way, he was not representing the folks that I saw in my recovery community at large at all. He was this exceptionally wealthy older white man with a lot of resources that weren't available to so many people in recovery that I knew. And as it turns out, that shows up in the medical evidence as well. So African-American folks really note that they feel extra perceived barriers when they're trying to access care, and they feel more discrimination. So they're more likely to anticipate discrimination. And then again, the word structural comes up, structural vulnerability. And I'll just read you what the conclusion on this one says. Structural and interpersonal factors remain sources of vulnerability, stigma, and anticipated discrimination for African Americans with substance use disorders and comorbid mental illness. So the idea here, and this, I just pulled this one, there's actually a lot of studies looking at structural stigma and interpersonal stigma for patients of color. So we know that patients of color, one of my, I hesitate to say favorite, but a research study that I thought was incredibly useful, though it's very old at this point, shows that cross-race time spent in an office visit, when you have a provider and a patient of different races, the time spent in the visit drops by roughly 6 minutes. So if you think about a 20-minute primary care visit, you lose 6 minutes if there is a difference in race between the provider and the patient, which is a lot of healthcare time. If the norm is 20 minutes, 6 minutes becomes a lot. And that's not talking about substance use disorders. And it is because we know there's significant structural barriers for folks of color moving through the medical system. It means that most healthcare providers are white, which means overwhelmingly patients of color get less time with their providers. And that's not even including the stigma of substance use disorders. So it means patients with substance use disorders who are patients of color or likely otherwise marginalized actually get less time with us. And then these qualitative interviews that people perceive more discrimination and are going to perceive more stigma in those office visits. And likely that's accurate. I want to give you guys just a very, very quick stretch break. That was a lot. We just covered a lot.